Good evening. Welcome. Thank you for joining us on this Thursday evening for our live orthopedic webinar series. My name is Andrew Goodwillie. I'm here to talk to you about ACL injuries, current practices, food for thought in 2019. I'll be sure to answer any questions you may have. There is a box available to you. You can submit any questions online and they will come directly to us. And at the end of our presentation this evening, we'll be able to get to as many of those questions as possible, and I'll be sure to leave some time to answer anything that you may have, any questions you have about specific cases or specific thoughts, and answer them to the best of my ability. So why don't we get started? So again, my name is Andrew Goodwillie. I'm part of the sports medicine program here at Northwell Health. I specialize mainly in shoulder and knee, but I take everything sports and sports medicine. So any athletic injury I'm happy to see in the office. So why don't we get started? So first, a little discussion about ACL injuries and the amount of healthcare burden that it has in 2019. This is actually some old data. This is from about 10 to 15 years ago, where there are about 200,000 estimated ACL injuries in the United States alone every year. There are about 100,000 ACL reconstructions performed annually in the US. And the bulk of ligament injuries around the knee, as you can see by our graphic, are mainly purely ACL injuries. And we'll go through reasons as to why that might be. So this is kind of our classic picture of ACL injury. If you watch the gentleman right on the right-hand side of the screen, as he goes up to celebrate a tackle, he comes down with a planted foot, his femur rotates, he fears a pop, and then he crumbles to the ground. This is kind of your classic non-contact ACL injury. Fortunately, we don't like to see people get injured during celebrations, but it's kind of your classic example as to how these injuries might occur. So what is the anterior cruciate ligament? Well, the anterior cruciate ligament is part of the knee. It's one of the ligaments that sits inside the knee. And if you look on the left-hand side of the screen here, you can actually see the inside of a cadaveric knee. The two kind of dotted lines show two what we call bundles of the ACL. It's not a single ligament, but comprised really of two separate ligaments that are intertwined that create rotational control around the knee, as well as stability when we perform activities and exercise. It connects the thigh bone, the femur, which is on the top, and then the tibia bone on the bottom. And if you look very carefully, there's around the bottom of that tibia, you can actually see the meniscus, or part of the cartilage, that has a very fine play with the ACL right in the front of the knee. If you look at the other part of the screen, there's two small dots, both a yellow and a red. That kind of gives you an idea of where the footprint is on a cross-section of the knee in a couple of different planes, showing you again where those two bundles are attached to both the tibia and the femur. So this is Derrick Rose when he had his time with the Bulls. Unfortunately, I use his injury as an example in the office when I talk to patients about ACL injury and the potential difficulty that they may have as they move forward through their rehabilitation. Unfortunately, Derrick Rose was not the player that he once was after this injury due to a number of factors. But this is, again, the classic history where there's a plant and pivot. You plant that lead foot, the tibia or your shin bone stays still, the femur rotates, and as it rotates, the ACL goes under tension and stretches and ultimately fails and ruptures. Most, again, of these injuries are non-contact injuries. Most individuals feel or hear an audible pop when they do it. The joint gets very swollen. There tends to be a lot of fluid within the knee. And obviously, you can't continue to participate without an ACL during that day. So when I see a patient come to the office and they have a large effusion or swelling of the knee, and they come in with a complaint of a non-contact injury, a twisting moment about the knee, and they felt a pop, there's a high likelihood that that might be an anterior cruciate ligament injury. So how do we figure that out in the office? Well, there are a couple of diagnostic tests. This first one is what we call the Lachman test, where you stabilize the thigh bone here with the left hand, and then with the right hand, you're actually dragging the tibia forward. So if I play that again for you, if you watch carefully, you can see the knee and the tibia really drag forward. That extra motion is instability, and that diagnoses an ACL rupture. Another test we can do is what we call the anterior draw test, where we literally just pull on the tibia and you can see it move forward. And there's different grading systems as to how far forward that tibia comes, as to how bad we think that ACL injury is. And the more it drags forward, the more we worry about other ligamentous injuries and potentially even cartilage injuries, meniscus injuries around the knee. The third test, which is very hard to do, especially in a patient that's just had a pure injury of the ACL, is what we call the pivot shift test. This is hard to see, but what we're doing here is we're applying a force on the knee, and we're trying to get the knee to almost dislocate and buckle. And that diagnosis, when we twist the knee and put a specific type of force on the knee, it shifts. And when it shifts, that again is diagnostic of an anterior cruciate ligament injury. And again, there's different grades to the severity of this test. And this is something that we typically utilize in surgery while the patient's under anesthesia, as opposed to in the office setting. So what does it look like on an MRI? Obviously, when you have an injury such as this, the next step would be to obtain more imaging. Usually we take an X-ray. The X-rays are typically normal. There can be little fractures or a little flecks of bone that pull off with this type of injury, but usually we go to an MRI. So what does it look like on the MRI? Well, here are two pictures. On the left-hand side of your screen, you can see an intact ACL. That's the black line connecting the two bones, both at the top and the bottom of the screen. And on the right-hand side, you can see more of that kind of white, cloudy material in the back, and that's all fluid or swelling. And when you look at the actual ACL fibers, they're not in continuity, they're not a straight line. And all of that white material, all of that white signal within the ACL is actually where the rupture has occurred. So this is what it looks like on an MRI, and something that we routinely utilize to just confirm an ACL tear, but also to look at the cartilage and the meniscus and any associated injuries. I get this question a lot in the office. Well, do I have to do surgery? Do I have to reconstruct my ACL? No, not necessarily. And if you have specific questions about this, I can certainly answer them at the end. About a third of patients are what we call copers, where if you have an ACL injury, a third of those patients actually do okay without surgery. A third of patients don't do well and ultimately elect for surgery. And a third of patients just go straight into that reconstruction because they know they want to participate in pivoting, twisting athletics. If you do decide to consider non-surgical management or non-operative management, you're going to be at risk of increased meniscus injury, more pivoting episodes, and increased injury to the knee. So further damage to the cartilage and to the meniscus, as you can see here on the picture on the right-hand side of your screen. There's also a question about the degree of arthritis, which I can certainly get into. And there's a risk that with an anterior cruciate ligament injury, your knee is then going to be at risk of arthritis, whether or not you go ahead with surgery or go through non-operative management. And if you go through non-operative management, the risk of developing arthritis is going to be higher than if you choose to do surgery. So surgery, right? I'm a surgeon. We're surgeons here at Northwell. We love doing ACL surgery. So what are we trying to achieve when we recommend ACL surgery? Well, we're trying to stabilize that knee joint. We're trying to treat any other conditions within the knee, meniscus injuries, cartilage injuries, and make sure that we address all potential pain generators within the knee so that we can get the athlete back to sport, back to work, and back into those pivoting, cutting activities. I wrote a question mark after prevent osteoarthritis on this slide because, again, even if you do decide for surgery, risk of arthritis is still going to be higher than if you'd never had that injury in and of itself. So we think we're good at preventing arthritis with ACL reconstruction, but we may not be as good as we think we are. So what do I do in a preoperative consultation with an athlete? An athlete comes in with their ACL injury and they're devastated. I think the majority of athletes come in and they know something bad has happened. They know that this might be their ACL. And with all the media attention that ACL injuries get, they have a lot of preconceived notions as to how it's going to go and what's in store for them. So I really try to set expectations well. Understand that an ACL reconstructed knee is never going to function quite as normally as a normal ACL would in, say, the other knee or pre-injury. And not all ACL reconstructions do well. Not all knees recover. And everybody's slightly different. There is going to be an increased risk of re-injury, right? Once you have an ACL injury, you're more likely to potentially injure it again. And in fact, your rate of injury increases even for the other side of the knee or the other knee. You have to consider various surgical options. When are you going to do this ACL reconstruction? Do you do it immediately or do you wait? What type of graft are you going to use? What surgical techniques are available in 2019? And what other considerations are going through my mind? And you have to accept that rehabilitation and rehab and working specifically with physical therapy is imperative to make sure that your anterior cruciate ligament reconstruction functions well and that you get a good outcome and get back to the sport that you want to perform. And obviously you have to accept the potential complications and risks that come with this type of surgery. So briefly about timing, either you delay surgery or you don't delay. Why would you delay? Well, you would delay surgery if the knee is swollen, stiff, or you have other injuries around the knee, or if you're in significant pain. If the knee is inflamed and hot and swollen, we actually let that knee cool down for a period of time just to kind of take away all of that all the inflammatory cells and mediators within the knee and allow your knee to recover before you actually go ahead for surgery. The problem is if you delay too much, you're at risk of additional injury. So if you delay further for over 3 months, you're increasing your risk of additional injury to the medial and lateral meniscus. So what do we do? Well, in that hot knee scenario, when it's warm and swollen and full of blood from the injury, we send you to our therapists, and the therapists do what's known as prehabilitation. And this is designed to really decrease the amount of swelling inside the knee, decrease the amount of scar tissue that may build up, improve your range of motion, and also improve your quadriceps strength, which when we talk about rehab at the end of this slideshow is very, very important. It acts as kind of the cornerstone of your rehabilitation. We know from studies out of about 420 hamstring reconstructions, we know that if you have good quadriceps strength before surgery, you're going to do better with post-operative quadriceps strength, and you're going to recover faster and potentially be able to do more at an earlier stage. So it's imperative to get that strength back even before surgery. So just a few comments about graft choice. There's many different types of graft. There's 2 questions you have to really think about: whether you're going to use your own tissue, which is called autograft, versus somebody else's tissue, which is called allograft. So that's the first question. The second question is, if you have an autograft to your own tissue, are you going to use your hamstring? Are you going to use your patella tendon? And now in 2019, something that's becoming more of a fad is using your quadriceps tendon to reconstruct the ACL. Each of them have their drawbacks as to where the graft is taken from, and they also have their benefits. Hamstring, for example, is a nice strong graft, the strongest of the 3. The patella tendon graft tends to be the gold standard, what we used to use, but it's associated with a little bit higher knee pain through the front of the knee and a bigger incision. What you need to know is you're not making a wrong decision any way you choose. They've studied this, whether you return to sport, re-rupture rate, rehabilitation, they are the same. So I do spend a lot of time with patients telling people that whatever graft you choose, it's the right graft for you. A word about allograft. Allograft is cadaveric or dead tissue that's been donated. It tends to be frozen. It tends to be irradiated so that the cells aren't living, so it's dead tissue. That tissue we can utilize and actually incorporate into your body. The recovery rates may be a little longer with allograft. And we know that in younger individuals, there's actually a higher risk of potential re-injury. So my personal preference is to not use allograft in younger individuals. But Bernie Back's group a few years ago actually tried to look at this between allograft and autograft and found that there was really no difference. So there's a lot of studies out there that suggest that it's equal, but there's a few studies to suggest that it may be associated with a little bit higher risk. In 2019, the reconstruction techniques of ACL have changed fairly dramatically. Even just a few short years ago when I was in training, a lot of the time we were using this technique, which is called a transtibial technique, where you try to connect the two bones and you just basically make one tunnel through the tibia and up into the femur and create a straight line, and that's where the ACL goes. Nowadays, what we're using is a little bit different technique where we're actually dropping down the ACL in its insertion point on the femoral side, on the thigh bone. And what that does is it basically puts the graft into a more anatomic and a more natural position on the femur. The proposed benefit here is that you get a little bit better rotational control of the knee when you do it this way, as opposed to the old way, which is going up through the tibia and into the femur. Sometimes we actually have an ability now to, instead of drilling up and through the knee, we actually drill from outside in. We have little drills that actually flip upside down, and we can actually drill backwards. So this is a novel technique that we can sometimes use. A few years ago, Freddie Fu in Pittsburgh came up with the idea of a double bundle, because again, if you go back to that initial slide, there were two bundles of the ACL that kind of twist on themselves. He thought, well, why don't we reconstruct both bundles? If we reconstruct both bundles, wouldn't that give us the best stability? Yes, it actually gives very good rotational control, but if you drag it out and just look at how patients do overall, double bundles tend to do just as well as our single bundle reconstructions. So this has become less used in 2019. What we do know is that no matter which way you choose to reconstruct, the best way is to get it in the right place. If you get the ACL reconstructed in the right place, you are going to have a good result, as long as it heals, obviously. So if you have a graft that's a little too vertical, it may decrease stability and rotation. You may have a little bit of difficulty with extension or flexion, depending on if it's in the front or the back. And sometimes if it's too far forward, the graft can impinge and actually become damaged over time. And that's something that we certainly don't want to see. So as long as you get the ACL in the right place, it tends to do very well. My personal preference is the old way of doing things, the transtibial tunnel. It's very hard to get a perfect placement on the femoral side, on the thigh side of the ACL reconstruction. So my preference is to use this more modern technique where we put the ACL in its anatomic position, and by doing so we can capture the whole ACL and the whole footprint of that old ligament and give you the best ability to return to pivoting rotational control around the knee. In 2019, there's a lot of research going into ACL reconstructions. There's a new fad. Way back when, we used to try to repair these. We used to try to put stitches in the ACL and reattach it to the bone. That's a newer technique, and that's trying to come back. There are a few surgeons out there that are trying to tell people that if the ACL peels off the bone, you can actually repair that back. I'm a little skeptical still, because we've known from old historical data that that may not work well, but it's an option. There's also options to, in addition to put the graft in, ligate the graft with sutures, and by putting stitches inside the graft, it may actually make the graft stronger. It may increase your ability to return to pre-injury activity. It may provide less pain because it gives a better constraint to the knee, but it doesn't over-tighten it. So a lot of people are starting to put stitches within the ACL graft. There's a lot of discussion now about, hey, the hamstring tendons. How do you perfect the size of the hamstring tendons? Aren't you born with a certain size hamstring tendon? So if you use that, is that just going to dictate the size of your graft? Well, yes. So there's new calculations, and we can predict now how big those grafts may be by looking at MRIs and predicting how big your graft might be if you choose a hamstring graft. We know that it has to be a certain size, and if it's below 8 millimeters, there's been a risk of re-injury to that graft. So a lot of us typically put in a little bit of extra allograft tissue or dead tissue in addition to your hamstring to bulk up the graft. But we may know now, new data suggesting that this may actually be detrimental to the graft and may actually lead to increased injuries. So what about rehabilitation? Right, rehabilitation is the core to recovery of ACL surgery. The first phase is reduce the pain and swelling. This is a painful operation. The knee gets swollen. So if you ice it, if you rest it, and really try to decrease that inflammation right after surgery, that's the best way to get your first foot going forward. Then you want to try to recreate knee motion. You want to gradually restore knee flexion, so bending the knee. But you also want to restore knee extension, meaning get it straight. The graft tends to be tightest in extension, so making sure that you're extended properly is absolutely imperative in the rehabilitation phase. So even a loss of a few degrees can affect your gait, and it makes it feel a little awkward. What we know is some people hyperextend, so their knee goes backwards. If that's the case, you want to try to recreate that what we call hyperextension of the knee with your ACL graft, because if you don't get it, the knee feels tight to patients. So you want to get symmetry between the knees. You want to individualize and adjust your rehabilitation program, especially if there's a meniscus injury, especially if there's additional injury to ligaments. And you want to make sure that the kneecap remains mobilized and that there's not a lot of scar tissue buildup in the front of the knee. The quadriceps is key here. You have to maintain quadriceps strength, and you have to maintain proximal strength and not neglect the hip. We know that the hip provides stability to the lower extremity. It provides stability to the knee joint. So you have to maintain good external rotation strength, hip flexion strength, and core strength in ACL reconstruction in order to maintain good balance to the lower extremity so that you're not going to have undue forces across that knee when you return to pivoting, jumping activities. Once you get your quad strength back, well then that's when the fun begins. Typically at around 4+ months in the rehabilitation schedule, we start working on dynamic strength, jumping, squatting, lunging, hopping, neuromuscular training, proprioceptive training, understanding where your knee is in three-dimensional space. You lose that ability when you injure an ACL because, again, you're putting in an unnatural ligament, and that's going to make it feel just a little awkward and a little weird. The old dogma here for return to play was 6 months. Right? When can I get back to play, doc? 6 months. Well, maybe not. In 2019, we're really trying to stretch this out, and we have good data to support that. When is it safe to return to play? Well, nobody really knows, right? This is a hot debate right now. There's biologic barriers. When is this graft really healing? We know that by 6 months, the difference between biologic healing between 6 months and a year is very minimal. So the graft is healed at 6 months, but the patient may not be ready. The psychological barriers, meaning that they may be apprehensive in terms of getting back to activity. There's physical barriers in terms of not being able to do certain things in their sport. So 6 months, I tried to avoid telling patients that they're going to be back playing in 6 months. This is old data, because we know that only 20% of individuals at 6 months have symmetrical knee function compared to their non-affected side. And that we know that if you have asymmetry with your knee function, you're going to have decreased knee function at 2 years post-op. So get that symmetry back before you go back to play, and don't cut corners. And if you look at this little diagram, this is a diagram I found where it kind of gives us a chance to look at, well, when do we start running? Well, we usually start running around 3 months, but even that, it can be very quick. Low agility training tends to drag out between 4 and 7 months, depending on, which graft you use. Jumping, pivoting, cutting, that's now 9 months, and with the full return at a year. So you're taking a year out from activity to get into your ACL rehabilitation and get back to quote unquote normal. If we look at data from the professional world, we know that NBA players have a high rate of success with the surgery. Kristaps Porzingis, I can rattle off a whole bunch. They're all going to come back and play in the NBA. But we know that they don't tend to come back at that elite level. They do drop a little level of function after an ACL reconstruction. 88% of NBA players do get back to the NBA, but they return in an average of about 10 months. And from NFL data, depending on what position you play, the average return to play is about 49 weeks. So that's up to almost 11 months. Most people consider ACL surgery successful, but even in NFL players, the recurrence rate and the revision rate can be upwards of 18%, so 1 in 5. And players in the NFL also don't really regain the same level of activity that they did pre-injury. So as physicians, we've really tried to come up with a way to figure out, well, when are you going to be ready? And that's a return to sport test. These are becoming more and more popular, and they're employed by our therapists to really try to figure out sports performance and help ensure a safe passage back to play. And some of the return to play criteria can be single hop tests, triple hop tests, crossover tests, running T-tests, and looking at your strength in certain degrees of flexion. We know that if you don't meet these criteria, your risk of re-injury increases. And so there's a lot of concern that even if you're passing these tests, you may not still be ready to go back to sport. So to finish, what can we do here? The ACL surgery is a big deal, and this is what I try to get across to my patients. It's a big surgery, it's a hard surgery, and the recovery is even harder. So what is the best thing that we can do for our athletes? Well, we could prevent it, right? So that we know that there's ways to prevent ACL injury. We know this through data that we've collected from female athletes that are at risk of ACL injury almost 2 to 8-fold compared to their male counterparts. There's a lot of different reasons as to why that is, whether it's the morphology of female knees, whether it's to do with laxity, hormonal differences, range of motion differences, genetic differences even. And what we know is that we can fix this problem. We know how to decrease the risk of injury. We know that if we improve landing mechanics, the risk of ACL injury goes down even after one simple session. And there's a bunch of different neuromuscular training programs that have been developed to really decrease ACL injuries and help reduce ACL injury. And we know that through different research studies. And here at Northwell, we have our own ACL reconstruction or ACL prevention program that's based on the Mandelbaum PEP program that we can employ to help decrease the ACL injury rate in our athletes. So I think that's a very quick overview of ACL reconstruction. What's new in the world of technique and surgical technique in 2019. We're always coming up with new ideas and new ways to think about ACL. There's a lot of research going into how we can progress ACL reconstruction techniques and really solve this problem. I think we're close and we're doing a good job, but there's certainly more we can do. The rate of re-injury, I think, is higher than the documented 6 to 8% all comers. And I think if you really focus on good physical therapy, a good return to play program, you can really ensure that you're going to get a good outcome and return to the sport that you love. So great, we are looking like we're getting some questions in here. This is my first time doing this, guys, so be patient. So a couple of the questions that have come in. When would you ever use allograft for an ACL reconstruction? So, great question. So allograft is difficult. It's a difficult question to answer. When you're in surgery and you feel allograft, and this is cadaveric tissue, so fresh or frozen donated tissue that's irradiated to sterilize it, what does it feel like? Well, it feels a little gooey, a little chewy, like chewing gum almost. So when you feel it, at least in my hands, it feels a little bit less robust. But I do use it. Why would I use it? Well, it's good for certain scenarios. It's good for my elder population that come in with ACL injuries, the skier that falls at Vail and, you know, they're 45 years old and they've got kids and they've got a career and they don't want to take much time out. Well, to decrease the risk of morbidity when they're harvesting the graft, an allograft is a great option. And again, there's a lot of studies to suggest that it's the same as autograft or your own tissue as you age. It's really in those younger individuals that I tend to avoid it. But it's a nice way to decrease pain from surgery. It's a nice way to just get through that initial phase of recovery easier. But if you looked closely at my slide deck, allografts do tend to take a little bit longer to congeal. The biology just takes a little longer. So I do tend to slow down people's recovery and return to play with allograft as opposed to autograft. So I would use allograft for my older populations above maybe the age of 40 and who don't want that donor site morbidity or the extra surgery that's involved with the taking of autograft or somebody of your own tissue. Here's another question here. I have a 14-year-old daughter who plays soccer year-round. I know as a female and one that plays soccer, and she has a high risk of ACL injury. Any suggestions of how to minimize her risk? Yes, this is always a concern, right? Okay, so where are the risk factors there? Female, young, 14, playing soccer, pivoting sport. Female soccer players have an extraordinarily high risk of ACL injury. Again, due to a number of factors. We fear that with female athletes in particular, there's a little bit more ligamentous laxity. There's hormonal control of ligamentous laxity that males don't have. The morphology of the knee is just different compared to male counterparts. If you look at the way the knee is shaped, the notch where the ACL sits is a little narrower. The ACLs are smaller. The actual circumference, or if you take a female ACL, it's just smaller in width. It's smaller in length, and so obviously the stress across it may be less in order for it to get injured. And we actually know that there's genetics here as well. Genetics plays a role. So we've seen lineages where a mother has had an ACL injury and her daughters both have had ACL injuries, and they've had multiple injuries, and they have a female cousin that's had an injury. So there's definitely a genetic component here as well. So how do you minimize that risk? Well, maintaining strength and function, right? There's a very quick, easy way to look at that. And by working with a therapist, you can actually look at mechanics and how they land. Again, the injury mechanism is a plant and pivot. If you're able to plant your foot and you have good trunk control and you land and your knees don't become knock-kneed and they don't cave in when you land, you're probably at less of a risk of ACL injury. So strengthening the quad, strengthening the hip, strengthening the core, practicing that landing mechanics will help decrease injury. And with a prevention program that Northwell is actually bringing to the community to different high schools, and if you're interested, we can certainly, I don't know if there's an email address that you can contact us personally, but we can actually teach athletes how to improve their proprioception, their ability to feel where their knee is in three-dimensional space, and go through a program, an intervention before they're injured to help decrease that risk. It's not foolproof, obviously, but it has been shown to make a significant impact on specifically female soccer players, which is where the PEP program that we utilize at Northwell was designed. Another question here, is there an artificial graft? Great question. There used to be. Back in the day, there were scaffolds where we tried to rebuild the collagen fibers of ACL grafts and ACLs and connect the tibia and the femur with basically a scaffold. They notoriously failed, but this was, my goodness, maybe 30, 40 years ago now, when ACL surgery was an even bigger procedure where you're in the hospital for 3 to 5 days. Open surgery, a lot of repercussions from that. So maybe that had something to do with the failure rate. Nowadays, there is some new science and new developments coming in with trying to get back to that scaffold, because we actually know a little bit more about biologics. We know how to grow cells. We know how to promote a cell environment for cells to regenerate into collagen fibers, and potentially on the horizon, this may become another option. It's not ready for prime time yet, unfortunately. Do you have any experience with Tom Brady's injury prevention program for athletes? From what I understand, it focuses on muscle pliability, pre and post training. I don't know his specific prevention program, but if you go, can I get back to my slide deck, guys? If you can load up my very last slide. It may be based on one of these different programs that have kind of come out from different places in the States. And they're all very similar. He may have his own where he's tweaked one of these programs to help, fit his experience with his own injury, his own ACL injury. But a lot of these different programs really focus on plyometrics, dynamic stabilization of the knee joint, strengthening, again, education on technique, warm-up, cool-down. So there's a lot of similarities between these programs, and I'm sure that if he has his own, which I am not familiar with, I'm sure it's based on these metrics as well. A question here is, are ACL injuries more common on turf than on grass? That's debated and hotly debated, whether turf has a increased risk of ACL injury just because of the way the turf is manufactured as opposed to pure grass. I think there's a myth and a misconception out there that turf will dramatically increase ACL injury and risk. That's never really been borne out in data that we have. The overwhelming odds are that it's very hard to test for, because if you look at all of different types of synthetic turf, it really depends on a whole host of factors, whether it's the amount of those small rubber pellets. What is the concentration on those pellets? What is the type of turf that you're playing on? What type of shoe wear are you using? What is the environment that you're playing in while on turf? Is it a slick field? Is there some dew on the turf? Is it, there's so many different factors that you would have to factor in for. It's very hard to test to see whether turf purely makes a difference as opposed to grass. What we do know is that sometimes cleats, if you look at cleats, the cleats where the studs kind of come up the side, those have been more prone to ACL injuries. So I would encourage whoever's watching, if you do have sons and daughters playing sport on turf, really try to not buy those cleats where the studs come up on the side, because there's a suggestion that might be more of a reason as opposed to the field type that they're playing on. A couple of maybe last questions here before we wrap up. So if you have some questions, make sure that you're firing them over. What is the long-term health risk of having ACL surgery? Well, I think that goes back to our, maybe I touched on it briefly in terms of ACL injury and the risk of arthritic change. The risk of arthritic change increases 3-4-fold after ACL injury. there's something to do with the actual mechanics and the pivoting episode that occurs at the time of injury that causes the ACL to rupture, that damages articular cartilage and meniscus injury. And if you have a meniscus injury at the time of ACL, the risk of developing arthritic change and maybe a poorer outcome is probably going to be higher if it's associated with a meniscus injury at the time of your initial injury. Arthritis can be devastating. When you look at ACL injuries on MRI, the articular cartilage takes a hit, even though it may not be damaged and you may not be able to see it with your own eyes at the time of surgery or on MRI. The concern is that, ultimately that pivot, that crush injury to the backside of the cartilage will cause irreparable damage to the articular surfaces within the knee. So the risk of arthritis is real, and you do tend to see that even within 10 years of ACL reconstruction and ACL injury. I love this question. Where is my office located? Well, it's located on 611 Northern Boulevard, just here in Great Neck. Our office number is 516-723-2663, and we can certainly get that information to you again. That's 516-723-2663. We're a multidisciplinary orthopedic practice. We have orthopedists that span from joint replacement, hand surgery, spine surgery, and we have a very excellent team of sports physicians, including myself, that can address any athletic injuries that you may have. So it looks like we're going to wrap it up. I really appreciate you taking time out of your Thursday evening to join us today. I sincerely thank you for joining us, and hopefully we can make a habit of this and have you tune in for other episodes upcoming. Thank you very much.